Good evening, everyone. Thank you very much for joining us tonight for this very exciting webinar. This is the first of a series of webinars that are put together by the Minnesota ACC chapter, really focusing on topics that are relevant to early and mid-career cardiologists. I had thought with Amber and the leadership at ACC about who can be our inaugural speaker, and we couldn't find a better one than Dr. Rihal. So he will be with us tonight for the next hour. We'll discuss topics related to setting priorities for early and mid-career cardiologists. And really, this was motivated by many talks that I've had with him before, and I really wanted to share with you what I have learned. And I think we appreciate that people who have registered send their questions. We'll try to address those questions in a big picture fashion. Before we go into the topics, I don't think Chet needs an introduction. I'll just make a brief one. Dr. Rihal has earned his medical degree from Canada and then joined Mayo Clinic. It's now 35 years. Was only interrupted for 3 years when he went back to McMaster University to start a PCI program back in the 1939. And then since he came back to Mayo, he's been an active member of the cardiovascular department. He's held a number of leadership positions. Most importantly, he was the director of the cath lab at Mayo, and then a chair of the Department of Cardiovascular Medicine, and currently the chair of the personnel committee for the system at large. So with that little introduction, thank you very much for taking the time, Chet, and welcome.
Thank you, Mohamad, for having me. I've been looking forward to this, and thanks for setting it up. And also thanks to the Minnesota chapter of the ACC for supporting it.
Right. So a couple housekeeping notes. If you have questions, you could send them through the Zoom chat box, and Amber will screen them. We have a fair number of questions, so we'll try to address some as they come, if the time allows. But the other component of this is we will talk about 4 broad topics here with questions in each. So if you want to tailor your questions, I think this will make it a much more fluid conversation. So we'll first start about the most popular topic from what we have gathered, which is choosing a career path and setting a priority for right out of fellowship. And then we'll talk about mentorship and leadership, and then we'll talk about professionalism and history. And finally, we'll talk about some professional satisfaction and take-home advices. So without further ado, we'll then start with the first topic, which is choosing a career path. But before I do that, I was going to ask Dr. Rihal, since he's a new addition to our social media platforms. I know that many members of our department have tried to get you on Twitter and Facebook and stuff like that before, and it just happened in the last few months. So I'm curious if you could share with the audience how that happened and what was the motivation for that.
Thank you, Mohamad. Well, this is a great story, and I think one of the pleasures and privileges of clinical medicine is the ability to mentor people. I'm sitting here with someone I'm very proud of, who's a mentee of mine, and we've got many others in our department. And the great thing about those relationships is that the learning is bilateral. It is not one way. And what Mohamad was able to do was really show me the value of joining various Twitter social media platforms, particularly Twitter, which I'd always kind of shied away from. But I think is what I've learned is if you use these platforms in the right way, you follow the right people, they can be a tremendous learning opportunity. And I want to thank Mohamad for that. He and I think Mac Ali showed me the way there. So it was a sort of bilateral mentorship. And it's been a fun experience. It's been great to connect with people from around the world and others that I've known personally for many years. So I think that's really the story.
Well, welcome to Twitter, and we enjoy your comments, and it's a direct way to interact with many people around the world, as you said. So thank you for joining us for that. Now, one of the most common questions that we got is how to choose a career path, when to start, and what is the big picture? I mean, does that start early in fellowship? Things may not be as clear back then. Does it start late in fellowship? And when is the good time to start a career thinking and planning for your career path?
Yeah, great question. So I'll answer this in a couple of ways. One is a larger, bigger picture. And most of these questions, I'll do that. I'll try to give you what my philosophy is in terms of thinking about questions like this, and then try to hone into maybe a specific example that others can take. So there's no one answer to a question like this. And the reason is obvious, is that we're all different, right? We're all individuals. And we have to make such decisions for ourselves. But in general, I would say it's never too early to begin planning your career path. And so if you think about, what is your goal and embarking upon a career in medicine or frankly in any field, in my view, the goal really is to have a long and personally and professionally satisfying career in life. If you can do that, I mean, you are lucky. And I think many of the people, around the table here and on the screen here are fortunate enough. I certainly feel very fortunate that I think I can generally say that. But there's a number of keys to successfully choosing a career path. And I feel that probably the key question is also the most difficult one, and that is to learn yourself, right? It's you cannot, and I would really advise us, do not try to become your mentor or your mentors. You'll never be able to do that. You really have to become your own person, and to do so takes careful introspection. It takes an understanding, which then this can take years, actually, understanding of what your drivers are, of why you went into medicine, and where your professional satisfaction comes from. You need to then couple that with your experiences. Specifically, what are you good at, right? And what you're good at may or may not be aligned with what you necessarily want to do, right? I mean, if I go out there and say that I want to become, I don't know, a pilot or something like that, I may want to do that, but I'm probably not going to be very good at it at this stage. So you have to couple yourself, your drivers, your sources of professional and personal satisfaction, along with your skills and talents. And if you can do that, that analysis will point you in the right direction, right? And in cardiology, of course, we've got great subspecialties to go into. We've got all sorts of imaging. We've got electrophysiology. We've got interventional cath, where I spend the technical part of my life, and so on and so forth. So I think it boils down to, Mohamad, and this is I think a philosophical answer, but I think it really is true. It boils down to learning and knowing yourself as part of your educational journey.
So
Now, one thing, by the way, let me just say one other thing here. Sometimes people will ask me, gosh, there's not going to be any jobs in this field or that field. And so I'm going to train myself for this or that or the other thing. I think that's a mistake. I don't think you should train yourself for perceptions of where the current or future job market is going to be, within reason. We do know that there's going to be a physician shortage in this country. We know that the population is aging. We know that the demand for healthcare is going to go up, not down. So I think there's going to be lots of opportunities for younger people that are choosing career paths.
So that's great. Thank you very much. I think your latter part of the conversation, or the comment, answered partially a question I was going to ask you. The quote that 90% of life is what I do or how I perceive it, and 10% is what happens to me. So I was going to ask you that question, and because a lot of structural fellows are, and interventional fellows are perceiving that there is a difficult job market. And I just got a call actually from one of my junior friends today, who asked me, I really like structural, but they're telling me there are no jobs, so I'm going to do peripheral. So it is kind of tough to balance that out, but certainly I had.
Let me just say this. I would encourage your friend to do what his heart says he should do. And I'll give you a personal anecdote, for what it's worth. When I was training, coming out of doing internal medicine and then looking for specialties to go into, cardiology was where my heart is. You know what I was advised in the late 80s and early 90s? That there are too many cardiologists, okay? And if anyone cares to, you can go back and pull up older issues of Jack, look at the various editorials and president pages that were published around then. The thinking was there are too many cardiologists. And so I was kind of like in the position of your friend. I kind of had my head down. Oh gosh, there's not going to be any jobs for cardiologists. You know, maybe I'll do vascular, right? I mean, vascular is a great field. It wasn't necessarily, you know, my personal first choice, but I was told, gosh, we need vascular specialists. Why don't you do vascular? And you know, I was describing this situation to someone, and what they told me is, this is one of the best pieces of advice I ever got, is don't listen to the naysayers. And if you train and you do a good job, there's always going to be room for you.
Yeah,
and I think that really is true.
I totally agree. I told him the same, actually. I told him that I heard the same exact words when I was applying, that, you know, there will be no job for structural people. So it's oversaturated. But my instinct was, then I'm just going to do what I like the most. And then we'll let you know, nature takes its course. So I appreciate that. So for people who have just joined us, we started our conversation talking about choosing a career path. And, you know, I am going to ask you to share what you have told us all when we graduated, you know, the first year out of fellowship, when you transition, you know, the couple pieces of advice that when the most difficult year is the first year, and what are the key aspects of that year that we should keep in mind?
Yeah. So again, this is great, and you obviously remember our dinner before you left after graduating. So, you know, one of the great things about medical training is that, and medicine in general, is that we never stop learning, right? So if learning is one of your drivers, it's very difficult to pick a better field. So as you all are aware, every step of training, whether it's medical school or whether it's residency, you go up a learning curve, and then you kind of plateau. You go to fellowship, you go up a learning curve, you kind of plateau. But the neat thing is, when you finish your training, your learning curve picks up really steeply. And for the first time in your life, you are where the buck stops, right? I mean, I'll never forget the first time I was at the cath lab and something was happening, and the nurse turned to me and said, "What would you like, Dr. Rihal?" And it was like, you know, it was just me. There's no one else. So the wonderful thing about transitioning from a fellow to junior faculty is that you continue to learn, but in particular, you learn about yourself. And it goes back to my first comment about choosing a career. You learn, I think, for the first time, how comfortable you are having difficult conversations with patients, with faculty. You learn for the first time how truly aggressive you are if you're a cath lab person, or what your skills are like if you're an imager. And that learning curve, I think, can really set the stage for a very successful first few years if you manage that first year correctly.
Awesome advice. Thank you. You know, we have gotten some questions about which career path do you take, academia and private practice, and I think that is a little bit tough to answer in this kind of conversations. Because it's too complex and many factors play in. But one thing that I think might be useful to discuss is that we have a number of people who are a few years out of fellowship at the 5 years mark, who have succeeded in their first few years. You know, they're technically good and they had good reputation and things are going well, but then they feel like they're lacking now this motivation and this, you know, surge that I need to move to the next stage, and they get stuck in the early career phase. And indeed, one really established cardiologist commented on Twitter when we posted this. He said, "Can you please define early and mid-career? I'm afraid I'm 10 years and I'm still stuck in the early career." So, what is considered early career, and how do we get out of it?
It's a mindset. It's not years. It's not a temporal association. It's a mindset. And you really have to have, I think, a vision for where your career is going. And I was going to talk about this later, but now is probably a good time. You know, as I've said now twice already, a lot of the success that we have in life or in our professions is understanding where our drivers are and understanding where our satisfaction. So it's the same when you're planning your career. If you enter a career without a defined plan, there is a real risk of getting stuck, whatever mid-career is, whether it's after 5 years or after 10 years. there is a real risk of it getting stuck. Now, and I realized this when I was appointed chair of the Department of Cardiology, and I looked at our staff satisfaction by age and number of years in staff. It starts out actually really high, and people are enthusiastic, and then somehow we manage to beat it out of them, and then it goes down, and then it picks up again. And some of my colleagues who've been on staff 25, 30, 35 years were some of the most satisfied, happy people that we have. And it's because I think with time, it wasn't just survivorship effect, but I think with time, they understood what was really important to them. And I think the trap, the mid-career trap that you're talking about, is falling into a career that's not truly professionally satisfying for you. And you have to get out of that. If you want to transition a little bit and talk, we can talk about drivers of satisfaction and burnout now or a little bit later. Maybe we'll just talk about it. So, yeah.
But I mean, what I hear resonating again is that it's really the first sentence that you say, that the most important, if you choose correctly, or if you go with what you're passionate about, and you know yourself, know your strengths, and we talked about this before, how difficult it is to know oneself, then the obstacles will be easier to tackle and move from one stage to another, much more than the surrounding.
I think in addition to that, Mohamad, if I can just amplify that, one needs to have a vision for one's own career, right? So if you're a leader at an organization, we have a vision for where your organization is going to go, whatever that organization happens to be. And then the leaders and the others in the organization kind of work towards that vision. What I see often actually is individuals don't have a vision or future plan for themselves. So you probably remember what I told you when you came on staff, or what I tell other people, make a plan to be the national expert in something, by 10 years or 15 years. And that'll give you an exciting goal that you can work towards. It also lets you prioritize your activities, because things that are consistent with your long-term goals, not just tomorrow's goals, but your long-term goals, are tasks that you should take on. And other things, howsoever important, probably are best done by someone else. And if you're working towards something, some sort of goal, whether it's, let's say, a professorship, whether it's a national leadership position, a local leadership position, or just being the best cardiologist you can be, whatever it happens to be, if you're working towards something, you'll be less likely to get stuck in ruts.
Okay, great. Thank you. So maybe we'll just tackle a couple more questions in a broad term about choosing a career path. I mean, we're going to take advantage of your current and prior administrator hat, and because that's a question that comes to trainees' mind. You probably know the curve that showed the amplification of administrator over time in the US since the 1980s, and the static number of physicians, and how most administrators are not physicians, and how that, we're a little bit spoiled here that we have a combined setup at Mayo where the administrators partner with physicians, but that's not the case in other places. So people are asking, is administration for everyone? And how do I know if it's right for me or not?
Okay, so two great questions. So three questions, and I'll just answer them directly, and then I'll expand on them. So first of all, I think it's very important that physicians and other healthcare professionals participate in the administration and management of our healthcare system. That's number one. Number two, it's not for everyone, okay? So then the question is, how do you decide if it's for you? And I'll just, again, tell you kind of an anecdote, and which I think is illustrative. I've had a long career in both clinical medicine and the administrative leadership side, almost kind of a dual career. But it was all serendipitous. This I actually didn't plan. I fell into it because my chair at the time, when I was a junior doctor, Dr. Tajik, asked me to participate or chair a work group looking at, it's the same old thing, looking at costs and reimbursements in the old angioplasty DRG, and how come we're not, we're in danger of losing money. It's always the same thing. And what I discovered is that I actually liked to learn about my environment. I liked to understand where costs are generated, how operations run, and I found it intrinsically rewarding to have input into my environment. rather than just showing up at work and going home again, I was one of those individuals where, I liked to talk about how should we run our clinic, how should we make our PCI program even more efficient. And I'll point out to everyone out there, this is sort of obvious, but you may not realize it. But when we're in an exam room with a patient or in a lab or an OR, that interaction is a professional interaction. But just about everything else it takes to get the physician into that room and the patient into that room is a business process. And, just like PhDs, we don't need every single physician to go and get business training and do an MBA, but we need a small percentage, I don't know, 5%, 6%, something like that. Just like we need a cohort of MD PhDs and not just have pure scientists running biomedical research. I do think having MDs, RNs, whoever, people who are healthcare professionals on the front lines involved in administration and leadership is very important. And what the data are actually showing is that health systems that have physician leadership, they tend to do better than those that don't. And so now increasingly, there's over 5,000 hospitals in this country, but what you'll see is that more and more of them are leaning on their physician colleagues for leadership roles. So I think it's very important. I think it's for a small subset. And it's one of those, discovery things you discover about yourself.
Great. So I think then we could move to, we have a few more questions in career path, but we want to tackle the other topics. So I think we're going to talk about mentorship and leadership. That's a very exciting topic to me, and I really enjoy talking about that. And you've been involved in the mentoring and development of many cardiologists across your career. What did you see as the most common mistake or pitfall that people fell into as they're trying to progress?
I think I've already sort of discussed this. So again, it's not knowing your true drivers and where your sources of satisfaction come from, and trying to be something that you're not. Right? I see too many people trying to become their mentors rather than trying to become their own person, or choosing a career path that they may or may not be ideally suited for. So again, it may be a little philosophical, but I do think it's true. In the long run, you've got to study and learn yourself as you go through this medical journey. And the converse is true. The people who get stuck and are not happy find themselves in careers where they're very, very busy, and they're not necessarily getting tremendous joy out of the practice, and within 8 to 10 years of burnt out. On the other hand, people who actually have found a niche that they love, it doesn't matter how busy they are. They can get tired, they can get mentally tired, they can get physically exhausted, but they don't get burnt out. And this is an observation that was very clear to me when I was chair of our department. And I've seen it over and over again, that some of the busiest people I know are also some of the happiest, because they're doing what they really love. And they've managed to carve their niche along those lines because they knew where their sources of satisfaction came from. Did I answer your question?
No, absolutely. And it's interesting you said that, the burnout and the markers of satisfaction and not satisfaction may not necessarily be what's around you. Maybe it's just that you picked wrong to start with. And I remember we had these conversations before where people try to fall into, a preset path, and they're just progressing through it. And that's how things are going. And then I remember when we were in fellowship, you would ask why, and I will take a step back and like, and then I will answer you, and they would say why again. So it's sort of like it brings this. Keep asking why until you get your true self, right? And then you'll able to be much happier. So
I do want to, let me just be a little more operational in answering the professional satisfaction question. It's not because I think there's a whole body of literature on this that it's actually worth reading if you're really interested in long-term professional satisfaction. So the person whose work I've read and I admire, and there's some great YouTube videos, is Dan Pink. And what he has discovered is that there are 3 major drivers of professional satisfaction, and you can relate these to yourselves. One is developing expertise or mastery over some body of knowledge or some area, whether it's operative, technical, imaging, but developing expertise in an area is very important. Second is peer recognition. Right? When you get invited to give a presentation, that feels great. When somebody refers you a patient, Mohamad, for a complex procedure, that feels great. That's a tremendous source of professional satisfaction. And third is autonomy. And I think autonomy is the one that many people struggle with because our healthcare system often forces us to cede autonomy and become just another, widget. But those are the three most important determinants of professional satisfaction, I believe, in addition to the more philosophical answer I gave you earlier.
Those are, I think we're going to highlight them in the tweets after this session, because I would say those are very important take-home points, because it's what we would like to strive to do.
And again, the citation is Dan Pink. I think it's important to cite, the person who did it.
Right. Okay. So the next question is, this topic is about mentorship and leadership. We sort of like touch a little bit about, mentoring and leadership, but a little bit more specific question about mentorship. It is a pretty tough thing to be a mentor, and you've had that before, and you cannot really mentor hundreds of people because it's time consuming, and you have really to put your heart and soul in it. But there is this distinction between, advisor, mentor, and sponsor, and whom should you seek, and what are the differences? So maybe you could comment on that.
Yeah, I think we all need people to help us in our career. We all need people to learn from. We all need role models, right? So, a sponsor, I think the way to use the word now is typically someone who literally does sponsor you for things. Someone who may call the ACC, for example, and say, gee, I've got a great young cardiologist for you, right? So they're actively pushing you and suggesting your name for career advancement in various organizations. A mentor may or may not do that, but a mentor, I think, will learn from. It's almost like an apprenticeship. Medicine in many ways, if you look at our training, it's more an apprenticeship, right? It's like a trade. It's not just scientific, right? We learn the art, we learn the science of medicine at the bedside with our mentors, from our role models. And I think it's very important. And for the people who are doing the mentoring, it's always bilateral. Right? Working with very smart medical students, medical residents, cardiology fellows, junior faculty, makes me a better cardiologist, right? Because it's always bilateral. It keeps you sharper. So those of us that do this, do it because we, again, find it professionally rewarding and satisfying. And it's tremendous to see, people like you. And in fact, I just got an email. I'll just give a little shout out and congratulations to one of our former trainees, Dr. Anthony Hilliard, who's just been appointed Chief of Cardiology at Loma Linda. And he followed a great career path and kind of knew what he wanted to do. And now he's, I'd say, mid-career, but, accelerating rapidly, and very happy as a result.
Oh, that's great. Congratulations. I will send him a note of congratulations. Yeah. I think I want to highlight one, this is a great advice. And I think having been in training just a few years back, I've noticed this on my colleagues, and I notice it even more now with fellows. If you're a fellow involved in a technical field, like interventional cardiology, whatever, I see the fellows focusing on, I just want to learn the skill. I just want to learn this, right? I have taken, and I think you've mentioned this now, that I've tried to learn everything, like a holistic thing, from each operator. So, when I go with Chet, when I go with Holmes, when I go with any operator that I have learned from, I try to, learn from their personality. Now, it may not fit me. Not everything would fit an individual person, but I really urge the fellows and the trainees to, there is always this little ego that, tell you, I know what I'm doing. I just want to learn the skill. I suggest that people keep an open mind and get that ego out and try to learn everything from every person. And then I think that learning attitude is what would help us the most accelerating. It personally, it's what has helped me the most. I have learned something very valuable related to technical skills are not from every single person I work with. So I
I
just,
think this is great advice you just gave them. And I can actually name the people that I learned the most from. I think I've got 5 or 6 people I can recall over the course of my training. And like you say, you try to take the best from your mentors, from your examples, from your role models. You don't want to take everything from them, right? But you take the best from the people that you're working with and incorporate it into yourself. It'll fuel your growth and long-term career satisfaction. Make sure you don't get stuck in that nuclear.
yeah, absolutely. I was going to ask you what was the most important advice you've got, but I think you've said it earlier.
I did.
Maybe we could say it again just for people who have just
Yeah. Yeah. So this again, this is just a personal example, but when I was training in late 80s and early 1990s, this is a long time ago now. There was this perception that there was too many cardiologists in this country. There's not going to be enough jobs, and a lot of us were kind of down about that. But the best advice I ever got is don't listen to naysayers. Do what you really want to do and become very, very good at it, and there'll always be a spot for you. And that's the advice I've given over the next couple of generations to various trainees. And as I look at those trainees, I love to keep in touch with them. I think they're all doing great because so don't listen, know yourself, don't listen to naysayers. There you
so
go.
great piece of advice. Thank you. So we'll now move on to the next topic, which was history and professionalism. I don't think we could have an official conversation with you, Chet, without talking about history. Right? Everybody knows that you're a history enthusiast, and would really like to know what you've told me. Every time I think I know a little bit about history, and I talk to you, and I say, well, I'm just going to give up on that because it's just too deep, and it's a whole career. But how did you develop interest in history, and what was the most important thing that you learned and applied it to your practical life?
Yeah, so great question. So, I've always sort of been a history buff, and I think it's because I like to understand why we are what we are, why we're doing what we're doing. And if you want to understand where you currently are so that you can build the future, for example, you have to understand how you got here. And so, whether it's just history of countries, politics, religions, economic, whatever it is, I really enjoyed learning about human history. And, medicine in particular is very special. So one of the questions you would ask me to think about is what's the greatest, threat that I perceive? I think the greatest threat I perceive is deprofessionalization. And to really understand what it means to be a professional and what it means to be a physician in general, you have to realize we are the heirs to a 2,000-year-old profession. Medicine didn't happen overnight, right? Mayo Clinic, wonderful institution I've spent my professional life at, has a 150-year history. It's one of the oldest medical institutions in this country. But medicine as a profession is 2,000 years old. So, those of you out there, whatever field you go into, let's say it's cardiology, because we're cardiologists. The history of cardiology is truly fascinating. And I'd urge you to spend, some time reading and learning about it. Learn about how blood pressure was first measured. Learn about when it was discovered that blood actually moves through the body and just doesn't just sit there cold, right? Learn about the first thrombolytic therapy that was given in the Soviet Union, right? I mean, learn about how Andreas Brunzig developed the first balloon catheters in this table. It's really amazing. And it will make you appreciate even more the profession of medicine and the specific field that you're going into. So I think as a backdrop in terms of just understanding how we got to where we are, it's invaluable to learn the history. So that has, in part, I think, really helped me, kind of round out my skills as a physician.
That's awesome. So what do you, I mean, you talked about deep professionalization or professionalism as
Yeah.
as the biggest threat that you see.
Yeah, I
Um,
do.
and how do we overcome that? I mean,
Yeah,
we're that's one aspect, and the other aspect is we're becoming very technical, right? Everything is about
yeah.
technology, and there is this art of medicine doctoring is almost gone. So, what is the antidote to this?
So yeah, so you've hinted at it, and so I'll talk about this. Talk about it in a little bit of detail because I do feel it's very very important. So I feel that the greatest single threat to us is deprofessionalization. Um, and if you really think about it, we can be replaced if we just become commodities, right? If we just become like you're saying, the technical aspect of what we do. Someone else can do that. I'm pretty sure I can train a technician to do a great coronary angiogram, right? I mean, in the operating rooms, we have technicians that open and close, and any technical skill you can you can teach anyone with eye-hand coordination and good fine motor skills to do. So even your technical skills could theoretically be replaced. So the antidote to this is don't let yourself become commoditized. And there's one thing that can't be commoditized, and I think is absolutely crucial, and that's the patient-physician relationship, right? So put yourself in the patient's shoes for a second. Let's say you're coming to see your cardiologist, you're having chest pain, whatever it is. The dominant emotion that you're experiencing is what? You're scared, right?
Mm-hmm.
I mean, all patients at some level, I think, have a fright or are scared of what could happen. And it's the physician's job to pick up on that, work with them to build a relationship based on trust. And here's what I've learned after a long career, you said, a 30-year career here. I think the most important aspect there is learning or remembering how to do a good history and physical. If you can do a really good intuitive history, you can tell whether that mitral regurgitation is symptomatic or not. It makes you a better cardiologist. It'll make you a better echocardiographer, a better interventional cardiologist. And you won't be able to be replaced. Likely no computer is going to have the haptic wherewithal to do a history and physical examination as well as we can in our lifetimes. So if you build upon and grow that humanistic aspect of medicine, it will complement your technical skills. As you know, Mohamad, I love doing procedures, right? And but the reason I can do high risk, tricky procedures is that patients give me permission to do so, just like they give you permission to do that, right? And the reason they give you permission is they trust you. And the reason they trust you is that you're honest, empathic, and you actually care about them. If you can do that, patients will pick up on that almost instantaneously. But if you come in as a young cardiologist and say, well, you can have bypass surgery or PCI, here's a list of risks either way, please let me know what you want. I mean, they can probably read that book. And so if you enjoy working with people as opposed to patients, so I tend to use the word people now rather than patients, I think it'll make you a better cardiologist. I think you'll have a more satisfying career, no matter what field you go into. And you won't be able to be replaced by the local EMR.
And robots.
And robots, right? That makes sense?
Yeah, makes great sense.
Yeah. So if you enjoy the technical aspects of what you do, right? The technical aspects are really fun. But remember, it's built on that foundation of connecting with people.
So, maybe since we talked about, connections with people and stuff, we've talked about this before about, innovation and building relationships and stuff like that. And again, this is the tunnel vision situation that unfortunately we get into where, I know 5 people in my life that, the manager of the clinic, the technical staff in the cath lab and stuff. So we're sort of restricted from opening our minds and building relationships. And we I mean, speaking of history, we talked before about how a lot of breakthrough come from interaction with, other disciplines and stuff. So maybe you could make a comment or two on that.
Yeah, sure. Thank you. Yeah, this is a really interesting thing. And when you think about progress in medicine or human progress, right, in any field, there's a couple of different ways that this can happen. One is slow, steady, incremental progress, CI projects, PDSA cycles, efficiency projects, you take out waste, et cetera. But then you have truly breakthrough or so-called disruptive technologies or advances that can happen. And if you look at some of them, it's almost as if they seem slightly crazy at first, right? And the inventors seem almost bizarre, right? So think about how Andreas Grunseg was first received when he described blowing up balloons in coronary arteries, right? Or the first person to blow up an intra-aortic balloon pump, right? Or when Elon Musk says he's going to land a rocket standing up on a barge in the middle of the ocean. I mean, I'm thinking, gee, this is crazy. And so there's an adage, it's not mine, and I can't recall where I heard this, is that reasonable people will always do the reasonable. Therefore, all progress depends upon the unreasonable. So there is this thing that we do need to stop looking at things the way we have always looked at them to make substantial progress. Which is why I think a lot of innovations come from the younger people and the people around this table here on this call, who will come into a field and take a fresh look at it and say, gosh, why don't we just do it like this, as opposed to the way we've been doing it for the past 30 years. And so having the perceptual ability to recognize there are different ways to do things or new ways to do things, I think is really important. So that's one. That's a long-winded way of that one summary. But the second thing I think is being open to learning from other people in other fields. So for example, I really enjoy watching neurointerventional radiologists work in the head, right? Not what I do, I don't want to do that at all, but they have some really neat techniques. And just recently, you and I had talked about something interesting we saw on Twitter. But I've learned from watching people from other fields do things that may or may not be applicable to my field, or maybe it'll inform something or give me an idea on how to do something better. So it's often pattern recognition and then joining patterns to create new morphology.
I totally agree. I mean, there was no worse answer for a fellow suggesting something in general is to hear the answer that, well, this is the way we always do it. So I think it's one of the privileges to work with people who can listen to, destructive ways of doing things. And even if it's great, even if it goes nowhere, but at least to keep that, to allow the mindset to open up and ask hard questions, I think it's a plus.
One of the challenges I always give the incoming structural heart fellows is that I tell them every year the fellows have improved at least one of our procedures, but coming up with a new way or a better way to do something. I mean, you remember this, and you and Mo, came up with some better things, and so that's a challenge that I like to give every incoming class. Think about what we're doing, look at it, and improve it.
Yeah, that's really an absolutely terrific thing to do. So we appreciate that. And as before I transition to our last topic, those who are still on the call, please, if you have questions, you could send them through the chat, either privately to ACC Minnesota or through the box to the whole group. If it's an operational specific question, it may not be the best venue to answer them because they're individual specific, but we'll be happy to connect with you and help with a specific situation. We're trying to get an overall picture here, but please, I encourage you to, we have 10, 15 minutes left. If you have any questions, feel free to send them through the chat. But you did touch earlier on the topic of professional satisfaction. And we had talked about maybe discussing a little bit about burnout. And I'll have to give you a disclosure here that anytime a trainee hears the word burnout, they lose interest, because most of the time it's, we're going to give you a lecture about how to sleep better, or we're going to give you a lecture about how to avoid, getting into a car accident after your call or something. And we never enjoyed those talks. So burnout has become a burned out topic for us. But I know that you have a little bit of a unique perspective. So I am going to ask you to make a comment or two on physician burnout from your experience and how to handle it.
Yeah, so no, thanks. Yeah, it's not a pleasant topic, but it is an important thing because, and I want to talk about suicide risk as well, which is separate but related. We've already talked about the major drivers of patient satisfaction. So I'd urge everyone to think about those, right? Think about why you're going into a field, think about your own personal drivers, and then think about developing mastery of a field, whether it's imaging, EP, intervention, whatever it happens to be, right? Think about how you can get peer recognition, whether it's publications, whether it's building relationships with referring physicians, whether it's spending more time with patients and their families, whatever it happens to be. And then think about the autonomy piece. So I like to approach this topic of burnout kind of in a positive way, trying to focus people on where they're getting the most satisfaction and ultimately joy in their practice. That's the best way to approach it. The converse is, we talked about the mid-career rut. If you get into a practice that's busy, but you're not really enjoying it, you're spending too much time doing clerical work, you will get burnt out. And all the studies have shown that physicians and other healthcare professionals always identify clerical burden as one of the main drivers of professional dissatisfaction or burnout. So you need a system, and your hospital needs a system to deal with it. There shouldn't just be one person dealing with the EMR all the time. We need a team approach to it, just like we do for clinical care. And we need to try to minimize, mitigate, and eliminate all of these things that are causing dissatisfaction. There's a lot of myths out there that we have to dictate 5-page histories of physicals. Well, the truth is we don't. But when I was chair, I had real difficulty getting some people to stop doing that. And because
I have to tell you how much I appreciate that advice, because I follow your style of notes. Maybe our APPs don't like that, but I get to the point and just write what's most relevant rather than spending so much time. I use that time to spend it more with the patient. So I think that's a great approach.
Well, I see two of our outstanding APPs on the line, both Jane and Sarah, and we make a great team. And honestly, it's that team approach that's absolutely critical. We're each contributing something rather than repeating what each other can do. And that is what a team is. That's what a highly functional team is. Right, Sarah?
She nodded, yeah.
Of course.
So, since the topic is professional satisfaction here, some people asked about, pitfalls and challenges they have, and without getting too deep into the specific situations, but can you talk a little bit about course correction? I mean, as because as you said, learning yourself is a long process, and you may, you may not have that on your first job. You may not even have it on the second job. So at what point what courage do you need? What kind of process in your mind that you said this is time to autocorrect course and then change path and stuff like that?
Yeah. So this is a terrific question, and I was just actually speaking with someone who has decided that they need a course correction in their career. So I think you need the perceptual ability to understand that your current situation is leading nowhere, or is going to make you unhappy in the long run, or that the colleagues you're working with don't have your best interest, or that your hospital is just using you to generate money and doesn't care about the quality of your work. So if you come to that realization, then I think it's very fair to begin looking for another opportunity. So that's on the job front, right? And there's many ways to look for other jobs. And, that's the perhaps even tougher course correction, though, is your own professional career. I have seen this. I have seen individuals who have retooled themselves, or retrained themselves. And I'll give you one specific example. He's not in the line, but our colleague, Dr. Pereira, he was the PI of the Taylor PCI study that we published in JAMA recently. And you may not know this, Mohamad, but Naveen went the very traditional academic cardiology route, heart failure, transplant. Then, as he was entering, I guess, mid-career, retooled himself by going to a basic science lab and learned, I mean, from first principles and working with a world-class mentor, pharmacogenomics. And then that led to, an externally funded, NIH-funded board, et cetera. So that's a very concrete example of someone who retrained themselves from a clinician to a clinician investigator, and then followed up with a more academic pathway. And he's not in the line, but you can ask him next time you see him. I think is finding that very rewarding. So, you have to remember a career is nowadays 30 to 40 years. You have to retool for 6 months or a year. It's not a big deal, as long as you're making the right choice. It can be a big deal if you've got family to support and you've got loans to pay off. It's not so easy. So it's better to retool or to course correct early if you find yourself in the wrong, down the wrong career path.
I think the example you gave is phenomenal, because it's a very successful career switch mid-career, and I think a lot of us are hesitant to make that call. And if you get to know yourself a little bit later, and ultimately what we're looking for is, as you said earlier, professional satisfaction and personal satisfaction. So we want to be happy. So if we don't. One pitfall that I see is early and mid-career people, like, they view happiness as just being on the podium, right? So if you go, oh, you haven't done this many cases, or you haven't been invited, so they create this myth that this is happiness, but it's really not. I mean, this is happiness for some people, but it may be not happiness for me. So
this is such an interesting point. We only have a few minutes. I want to make a couple of points here before we're going to have to wrap up. One is that I really do believe, after years of being a chair, studying this, talking to people, that no one else can make you happy. No one else can make you satisfied. There's only one person in the world that can make you satisfied and happy, and that's yourself. And in a way, it's a bit of a decision. You can look at your job or your practice and say, gosh, you can look at all the negative aspects of it, or you can look at you're a very positive person. You can look at all the positives. And in a way, it's a choice. It doesn't mean to say that you can will away problems. You have to recognize and work on problems and mitigate and eliminate the dissatisfiers. But just eliminating dissatisfiers does not cause satisfaction. It just makes you less dissatisfied, right? So you have to, at some level, decide, I'm going to be happy, and this is how I'm going to manifest it. This is what I'm going to do. And then you'll find it becomes a virtuous cycle. Let me just switch really quickly to the opposite end of the spectrum, and that's physician suicide risk. Because we had said that we would talk about this. Physicians have now passed dentists, I think, as the professional group with the highest suicide risk. I think it's like 400 per 100,000. There's over 1 million physicians in this country, which means like 2 a day that in America that unfortunately would average out. And a lot of people think it's related to burnout, but it's really not. It's usually undiagnosed mental illness, and there's lots of barriers for physicians and other healthcare professionals to seek mental health care. For example, all the credentialing forms, right? They're very intrusive. And so what I would say to people out there, probably no one on this call, but if you know people you feel are, may need help, don't forget, we are a high risk group now. So help your friends and colleagues, help them get the help that they need. And most organizations will have anonymous ways of getting help to physicians. So it's not exactly the same thing as burnout, but there's no doubt that we're seeing, a high rate.
Yeah,
So that's a bit of a downer, but I thought it was important to just bring
it
that
is.
up.
I mean, it's to double the number of the general population, and
Yeah.
I expect that this will just continue to go up as we become more,
Yeah.
materialized over time. So that's an important thing to touch on. Thank you. Maybe we'll just finish with a couple wrap-up comments and general advice about what should people on this call, mostly are between 1 and 10 years out of fellowship, take home with.
Yeah, so I think I've sort of mentioned this a few times. I really do feel it's a privilege to look after people. If you like working with people, whether they're patients or colleagues or whatever, you've picked a great profession to do so. Focus on professionalism. Don't get commoditized. Build relationships. Be innovative. And all of this boils down to, again, I'll say it again for the 10th time, learning yourself and leading and managing yourself throughout your whole career.
Thank you.
Thank you for this.
Maybe I'll just wrap this up with a little bit of a joke. By the way, guys, Dr. Rihal would not allow anybody to call him a provider, speaking of professionalism. So we do have to mention that, right?
Oh, we have to. So this drives me nuts. I was trying to restrain myself. None of the people on this call went to provider school, right? I mean, if you're an NP, you're a nurse practitioner. That's your profession. If you're a nurse, you're a nurse. Nursing has a great tradition, going back to Florence Nightingale. If you're a physician, 2,000-year history, right? I didn't go. Did you go to provider school? No.
I don't know where that is.
No. So don't let anyone commoditize you or call you provider. Have your self-respect as a healthcare. That's just my little pet peeve. Thank you.
I think that's a good way just to wrap up. And would like to thank you for taking the time. Thank Amber and the ACC for arranging for this. Hopefully, we'll have a lot more discussions in the future about topics that are relevant. I mean, one thing that we tried to do today is really touch on topics that are relevant. Like this is important to me. I don't want to just hear about general stuff. I want to hear about from experienced people who've mentored a lot of cardiologists, what they have noticed, and how we should move forward. So thank you for taking the time for doing this, and we look forward to having much more of this. And maybe this is not the end. Maybe we'll continue this conversation on Twitter.
Okay. Have a good night, everyone.
Thank you.
Thank you. Thank you, Mohamad.
Thank you so much, guys.
Thank you.
Thank you.